Nothing to disclose except for Dr. Ravi Bains, whom I've learned this ALIF technique. He is the one who's taught me everything, and he's also contributed to these cases which have been done in my fellowship days. So, the first case, 73-year-old gentleman complaining of right leg pain and claudication. Pain increased on walking and was completely relieved on sitting. This is an important information for me, that whether the pain gets completely relieved on sitting and lying down, both. And it was not relieved by conservative means. There was a history of L5S1 discectomy 15 years back. X-ray shows complete collapse of the L4-5 and L5S1 disc space with the asymmetric collapse over here at the right side at L4-5. Flexion extension views show some gap vacuum sign at L4-5 and L5S1. Now, this is the MRI showing more of foraminal stenosis bilaterally at L4-5 and L5S1, both on the right as well as the left side, and some component of central stenosis at L4-5. And the axials again show central as well as lateral recess stenosis at L4-5, previous laminectomy defect. And yeah. Now the plan was to do L4-5 and L5S1 anterior lumbar interbody fusion. It's done through trans-abdominal retroperitoneal approach. Usually at our center, we never use an access surgeon. So it's important to know the vascular anatomy before you perform an ALIF. So the bifurcation of the aorta and the confluence of the left and the right common iliac veins is somewhere below the L4-5 disc. And there's this iliolumbar vein that goes below the L4-5 disc and dives deep into. So you need to know that you need to ligate and retract the vessels to reach the disc space. And once you're down there, you get a beautiful view of the disc. And after this, the surgery is just like the ACDF. So the same patient, the iliac vein and artery being mobilized immediately, use a blunt Kittner to push away all the soft tissue over the disc space, which includes the sympathetic plexus also. Do not use much of bipolar over here because that increases the risk of having the sympathetic plexus injury. And once you're here, once you put your retractors, everything after this is just as simple as doing an ACDF. You get a beautiful resection of the ALL. You use your cogs, use your curettes to prepare the disc space. Put in the ALIF cage, which is quite a big, large cage. Choice of bone graft is yours. You could use the autograft, allograft, BMP, and then put in a plate over there. And boom, that's done. Do 2 levels again, and this is the final picture. So from 30 degrees of lordosis, which was their pre-op, we could reach to 50 degrees. The patient went home within 2.5 days, had a good outcome, no pain after the surgery. Second case, a 65-year-old lady had L5S1 discectomy about 7 years back, and now started complaining of axial back pain and left leg pain. So you see again the nerve root being trapped over here, and left side foraminal stenosis at L5S1. So again, we did a L5S1 anterior lumbar interbody fusion. In fact, doing L5S1 ALIF is one of the easiest things to do because you don't really encounter vessels. You do not have to mobilize too much. You just get down into the bifurcation, locate the L5S1 disc, cut the central sacral artery and put in your implants, and you're done. So again, from a 17 degrees of lordosis at the L5S1 level, we could reach to 28 degrees. No going back, no pedicle screws, nothing. So the advantages of this approach are that it's a minimally invasive approach. It's a completely new corridor. You do not encounter all the epidural scarring, epidural blood vessels, no nerve roots around. And it's not as dramatic as you look at it in this picture. You just mobilize, go into the retroperitoneal space, mobilize the soft tissue over the disc space, and enter over there. You get a beautiful indirect decompression with the ALIF. And you get a large fusion area, large surface area for fusion. So you can almost remove the entire disc space, and that itself acts as a big area for fusion. And the footprint of the ALIF cage is so large that it almost occupies the entire vertebral body, and it sits on the apophyseal ring of the vertebra, which is the strongest bone. Compare it to the TLIF cage, which is small and it sits right into the center of the end plate. And ALIF does not need any fancy technologies, no neuromonitoring, no OARM, no navigation, no robotics. It just needs good surgical training and precision to put in those implants. And you can achieve great segmental lordosis through these implants and great sagittal balance. So talking about sagittal balance, this is a 66-year-old lady, had a 3-level lumbar decompression about 20 years back, had progressive scoliosis, and had left back pain, fatigue, and posture issues. So these were her sagittal parameters: lumbar lordosis of 17 degrees, PILL mismatch of 43 degrees, hypokyphotic chest, SVA 14 centimeters. So in a center, the protocol was to do a staged ALIF first, and then after a couple of weeks, the patient comes back. So in between, when we did a 3-level ALIF, you already see there's a great improvement in the sagittal balance as well as the in most of the sagittal parameters. Lumbar lordosis, we gained 33 degrees by doing a 3-level ALIF. PI to lumbar lordosis mismatches within 10 degrees, which is the acceptable limit. The thoracic kyphosis also changes once you change the lumbar lordosis, just like Dr. Ayush showed in his cases. The SVA went down from 14 centimeters to 1 centimeter. So there's no other technique that can really improve all your sagittal parameters better than the ALIF. And of course, you do a second stage all posterior fixation for this to correct the residual deformity. Now, why do you gain so much of lordosis, or why do you get a great indirect decompression through ALIF? It is in this video. So you can put in a paddle distractor and distract as much as you want. Of course, not be as aggressive as it is shown in this video. This is just for representation, but yeah, you can distract the disc space. You can put in a good size interbody implant. Of course, the goal is not to overstuff the disc space, because you risk you get into a risk of end plate fracture, which again could be catastrophic to the patient. So there are certain limitations to this. Implant availability, this was the limitation about a few months back, but now we've personally designed these ALIF cages, which are down into small, medium, large footprints, varying angles from 5, 10, and 15 degrees, with anterior plates as well as all instruments and retractors needed for ALIF now. Need of autograft or allograft? Yeah, you need to either have autograft from the iliac crest, or you could use allograft, or you could use BMP in these patients who are undergoing ALIF. Some patients may require posterior fixation. Those are the ones who you've operated for deformity correction. You need to augment this with posterior fixation. Very osteoporotic patients, or patients who require further posterior decompression even after doing an ALIF. Those are the patients who I would want to fix in posteriorly as well. And surgeon training, because this has always been an unfamiliar approach, but this can be tackled with courses, tutorials like these, and we could train more and more people to do this. All in all, I think if one can do an ACDF, we heard dealing the major setback that usually surgeons have, that while doing ALIF, you're dealing with a lot of the large vessels, and that could be a risk. So I always say that if you can do a good ACDF, then the ALIF 1 level or 2 level is not too far off. You just need to train yourself. And we did a project in Kaiser that says that you need to watch over or assess 50 cases, up to 50 cases, to be good at it, and not use an access surgeon for this. So this is definitely doable, and this technique has a good future for revision spine surgeries. Thank you, everyone. Thank you for your patient listening.